Video on.
A very good evening to one and all present here. On behalf of KAIRALI Society of Oral and Maxillofacial Pathologists, I am honored and delighted to welcome you all to today's webinar. Today, it's my privilege to introduce to you a distinguished speaker whose contributions in the field of medicine have been nothing short of groundbreaking. Dr. Anoop obtained his BDS and MDS degree from Mahatma Gandhi Postgraduate Institute of Dental Sciences, Puducherry, India. He was a professor and postgraduate research guide in the field of oral pathology. Dr. Anoop is not only a clinician but also a visionary researcher who recognized the potential to revolutionize drug delivery systems for various diseases. He founded his own research company, ANOOP Research Group, where his team's relentless pursuit of excellence led to remarkable achievements. Under his leadership, the company has successfully obtained multiple patents for novel drug delivery technologies. His pioneering work extends beyond the lab, influencing both academia and industry. Dr. Anoop's research has not only advanced our understanding of various pathologies, but also opened new avenues for effective treatments. His commitment in improving patient outcomes through innovative solutions has garnered admiration and acclaim within the field. Please join me in welcoming Dr. Anoop, whose dedication to scientific discovery and entrepreneurial spirit continues to inspire us all. I welcome you, sir. And the moderator for today's session is Dr. Deepu George Matthew, Professor, Head of the Department of Oral Pathology, ANOOP Dental College, Montebura, who himself is an entrepreneur as he has established his own state-of-the-art laboratory specializing exclusively in the field of oral pathology. I welcome you, sir. Over to you, Anoop, sir.
Thank you, ma'am. Thank you for that great introduction. This was the best I had so far. Thank you so much. Hello, good evening, everybody. I am Anoop. I am an oral pathologist, and I currently lead a research team, an independent research team, and we are working on a couple of clinical breakthroughs. Today evening, we will be discussing on the potential of oral pathology to as a hub for unicorn startups. And I will also be sharing some of the experiences I had during this research journey, so that it is useful for, in case some juniors are around, it is useful for them. So, can I start the presentation? Share the screen. Okay. Share. Window share.
Good evening, sir.
Are you getting it? See? Full screen. Then slideshow computer. Full screen. View slideshow. From beginning. Full screen. Chair. Are you getting it, sir? Full screen?
No, it is not in slideshow.
Slideshow. No?
No.
Slideshow on the screen. end show first. End show slideshow from beginning. Is it? Not it? On current slide. No?
No, can you try again? Can you share the screen again? I feel you have to go to share screen. You have to leave your PowerPoint open and share the screen.
Share screen.
You can close it and do it again.
You open it will open the screen. Sure. Is it okay now?
No. Tara,
No, ma'am.
can you guide? Can you please guide? You have done it now, no?
Yes, sir. Sir, the right side, the right bottom, there is an icon. Right bottom of your slide, there is an icon.
Hello?
So one of the icon, when you click, no, that will just, the full screen mode will come.
Right click on it. No problem. Stop sharing. The first I will open
Tiny screens.
it will open பண்ணிட்டு கீழ PowerPoint. இது ஓபன் பண்ண முடியும் நம்ம ஸ்கிரீன்ல. No?
Yes, 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 sir.
I'm a camera. Full screen share. Full screen. Are you getting full screen?
Yes, sir.
Okay. Next slide. Okay. I'm not able to change the slide. Stop sharing connection already. So to start with, the beauty of, can I start? Yes?
Yes, sir.
Okay. So as we know, the beauty of oral pathology is it's at the crossroads of dentistry and medicine. You may say I'm biased, but still I would say that oral pathology is the connect between dentistry and medicine, because the foundation of oral pathology is based on the basics of medicine. So if we are going to work with a multidisciplinary team, this is a big advantage for us because we can coordinate between medical teams as well as the dental teams. And not only that, when we compare ourselves with the other non-clinical areas like biotech and other life sciences, for example, they have high-tech research. They are doing very advanced research, but when it comes to bringing it to the clinical side, they have limitations in handling the clinical side because they are neither experienced nor they are licensed to handle the clinical aspect of it. So from that point of view, we are in a very highly niche, very special position as oral pathologists, wherein we are able to coordinate between medicine and dentistry. We are able to correlate between clinics, between preclinical and clinical, and this gives us a special position in research, which till now we have not been using as oral pathologists. The reason we have not been using it as oral pathologists is because we ourselves have traditionally limited oral pathologists. We are restricting it to teaching as well as diagnosis. Beyond that, we have not pushed it, though we have a very high potential to do big things in medicine and dentistry. We have not tried so far to push it into that because our focus is very limited, and we are focusing on teaching and diagnostics. Because of this, if you see, the opportunity for the newcomers or the juniors has been quite less, because teaching is of course a highly intellectual demanding field, and but the positions available are comparatively less, and this has led to decrease in choice among the youngsters in picking up this specialty as their choice. But from my experience, if we could a little bit change this concept from oral pathology focusing only on diagnostics and teaching, if we could just extend it a little bit, make it a little more divergent thinking, so that we start focusing on research which can be taken from the lab to the clinics. It can make a huge difference. It can make not only in the opportunities for what I call it as the juniors for the oral pathologists, but it can also help us in creating jobs, creating more opportunities by helping us start startups which can have high potential in our field as well as in the medical field. Now, for that reason, the general concept what we have is, when I was called to give a talk in an institution recently by my friend, and one of the important things they told me was, we will be calling the final years and the interns for the discussion. I mean, the interns and the PGs for discussion. So I asked them why you were calling this interns and PGs. They said they know the subject more. No, the main thing what we have to understand here is, it's not the subject that matters, the subject knowledge that matters. What matters here is able to generate ideas. The normal concept now is you should have interest, you should have a passion, and then you will be able to do things. This works for very well when you are going to choose something called as a profession. You are going to choose your PG subject. In those conditions, it will help to have the interest and to have the passion. But when we are going to do something new which is not existing, and you are going to bring that idea into a concept, there you need to have a slightly different attitude. This attitude will be how you are able to identify challenges that are existing around you, how you are able to identify easy solutions for those challenges, and how we are able to take this idea, build it up step by step, and bring it to the clinics, and finally give it to the patient in a format which is useful for the patients. For this, we need a completely different mindset, and this has to be trained, I feel, in the first year of UG, not at the end of internship or at the beginning of PG, because that much time we are wasting. And this is a skill set which has to be inculcated when the students are in, when they're starting early, so that they start looking at the things around them in a more inquisitive way. That is the way to develop this type of concepts with respect to clinical research. We cannot depend on our core knowledge to do this. The core knowledge can help us in developing an idea into a product. But to get an idea, that the general traditional concept of passion, interest, all this can be used to develop, after you develop that idea, to identify challenges, find out solutions, and then you pepper it with interest and you pepper it with passion, you can take it forward. So one of the things that we have to do is in academics, in the beginning itself, we have to bring this concept into this. And I would like to thank my professor, because even when we were starting the PG, he gave us a free hand to do the research of our interest. And to a great extent, I think the entire batch, which is right now over here, we all have, benefited from that approach. So the first thing I would like to say is, first develop an idea, have the tendency to develop an idea. And now when you develop this idea, the next question that will be coming is, how much should be this idea? It should be a big idea that you go and disrupt, or you can, even a small idea can disrupt. To know that, you should both the types of ideas are very important. If it is a small idea, we call it as an incremental idea. If it is going to change the field completely, we call it as a radical idea. But both are important. For example, in this, as I am showing here, you have two types of implants, and initially these implants were all parallel walled, like how you see on the right side. Then one day, one dentist got up, he got an idea, why all the roots of the teeth are more conical in shape, and we are putting a parallel walled implant. Why don't we make it a tapering implant? So he calls up the CEO of a company and says, I want to get this idea into it. They were interested in it. That's how this type of tapering implants came. Now he's traveling all over the world giving lectures, and the concept is he just changed it from a parallel walled implant to a tapering walled implant. There is not much change, but it had a huge change with respect to the the surgical protocol, where it can be used, where we could use it in narrower bones. So from a clinical point of view, it had more effects, though the innovation was very minimal. So for this, you needed to be a dentist, because only then you will be able to identify this type of innovations. Similarly, as I showed down here, we have a connection between the implant and the abutment. Earlier, it used to be something called as an external hex. Now, another dentist came and he checked it out and he said, if we make it as an internal hex, we have more stability. And then he marketed it to the companies, and he was able to prove that the internal hex has more advantage than the external hex. And now he is an owner of airlines. And the main thing he did was, he just changed an external hex to an internal hex. This type of innovations, these are very minor innovations, minor changes, but they have huge effects in the complete system. So for doing this, of course, you need more knowledge. This is one type of innovation which we do in our own field. This is also important. This has its plus and minus, because, for example, if you are going to innovate a small part of the device, then you also have to get the support of the company to add that to the device and market it. If you don't have that, you will not be able to market it. That is the negative side of it. The positive side is, already you have a big market, the companies are already marketing, they can easily add a small correction to that and they will be able to sell it. These are the pros and cons of incremental innovation. For this, you need to be, of course, a specialist who uses this so that you can identify modifications and develop it. Now, coming to the other one, that is what we call it as radical innovation. In the case of radical innovations, they tend to change the field completely. Before implants came, we had the options of only RPD, you had the complete dentures, and you had crown and bridge. Now, once this implants came, it changed the entire treatment plan. It has brought in a new field called implantology, and so much business is running on that. If you go and check what are the top companies, top medical device companies in the world, you will be seeing within the first 50, you will be seeing Dentsply, you will be seeing Straumann, and you will be seeing Zimmer. All are dental implant companies. So this much effect it has had on the economy, as well as it has changed the field. But if you see who did this, Brenmark, he was an anatomy guy. He didn't go to it thinking about it as a dental implant. He was reading, he had placed some small cages of titanium in the femur of rabbits. He was studying more about blood flow in the femur. And then he identifies that this box fuses with the bone. The beauty of that was he was able to translate that finding which happened in the lab to something clinical. And the reason he's identified the mouth was, mouth is easy to access. You can place the implant easily compared with other parts of the body. And his first implant, when he placed the implant, then he thought more about it. Why not add a crown to it and make it like a root, like a tooth? So the first implant he placed, it survived for 40 years. Now, in this entire story, the beautiful part is somebody does an experiment, unrelated experiment in the lab. He finds something that the bone is fusing with it. He's able to think and bring it to the oral cavity, convert it into something useful for the people, and able to market it as a product. This is the part of clinical innovation which we can do in oral pathology, and which we are not doing because we are still more focused on publication sort of research that is going on. The maximum we are trying to do is more of community or publication. We have to just open the doors of the lab and think more about how we will be taking it from the lab to the clinical side. And once we do that, we are opening up a completely new branch of we are opening up lots of opportunities in oral pathology, and it is limitless. And the same thing, what I would like to talk about here is, this is the aligners. The aligners were not identified by orthodontists, PG students, or by dentists. There were 2 MBA students who didn't want to wear braces during their meetings, etc. So both of them sat together. They thought, why don't we make something which is without wires? So that concept is what which has resulted in aligners. It is a multi-billion-dollar business today in the world. Implants also are such a billion-dollar business in the world. Everything started in the lab, and these guys were not dentists. That is so. What I am telling you is, it is the attitude to think divergently, to think, to have a plan B when you are looking at something, and use it in so that we are able to use it clinically and for the benefit of patients. That is what is going to happen. And now, if you see here, even in this, implants are also going to be phased out in the short run, because Kyoto University, I think in September, they are going to do a human trial where they are going to inject antibodies against USAC gene 1, I think. They found that if you are able to stop that gene, we will be able to initiate tooth bud formation, and we will be able to regenerate tooth. I think the first human trial is going to happen in September 2024. So we have lots in our bag as oral pathologists. We have tissue regeneration. We I will show you the other opportunities that are available as oral. What we need at this point of time is just a change of, how we look at research a little bit away from the academic point of view, so that we can open the labs and take it to the clinics and to the patients. And as you see here, this development phase is not an easy phase. Like how we do a study in the in our labs or in the academics, usually we get a small study done and we get it published. It is slightly different when you come into the industry or the commercial side, because here we have to develop an idea. That idea has to be taken to the lab. If it is a device or something, then it goes to the mechanical lab. You make a prototype of it. Then from there, you have to go to preclinical side, where you have to prove that the idea works in animals. From there, you take it, go to the regulatory officers which are in each country. You get permission from them to do the study, then go to the clinics. And then it goes for the market analysis. Though it looks like a long procedure. For example, here, I'm showing you the different things we have for device studies separately and the drug studies separately. We have, for device, we have pilot, pivotal studies, and for drug studies, we have phase 1 to phase 1. Now, these are all huge studies, requires crores of money to do the study. And the question will be how, as individuals or as academicians, we are going to do this. Now, the issue is, when you are having an idea, the first thing we do is we go and patent it. If you are lucky, if some company likes the patent, they take it from you, buy it from you, and you should be okay with it, with the remuneration you are going to get for it. Most of the times, what the companies tell you is, you go and get the proof of concept for us. We don't want to do the proof of concept studies. All the big companies, if you see, they won't like to do the proof of concept. They ask you to come with the proof of concept. So to get the proof of concept, you need to do the preliminary study. For doing the preliminary study, you need funding. When you go to the funders, they say, you also show the proof of concept, we will do the funding, whether it is a government agency or whether it is a venture capitalist or etc. So basically, the problem with medical or dental studies is, we have to approach people by doing a basic study. Once you do at least 1 or 2, as preliminary studies, which show some signs of it works, then you can go and get the funds and then develop it from the idea state to the prototype to the preclinical. For each phase, we have funding available. And if this funding you can use it to develop it into what you call it as to take your idea from stage 1 to stage 4. Now, once you have completed a pilot study in device, or you have completed a phase 1 study in for drug studies, the companies will be ready to negotiate with you and take it. From there, they will be able to take it out. The beauty about this is all that which I'm saying up to the pilot study or to the phase 1 study, we can do it in an academic environment. So oral pathology should be the area where all the blockbuster studies in dentistry must be happening, because we are the people who can coordinate the clinical side with the preclinical, also the medical with the dental side. And just to give you an idea of the markets or the opportunities that are available in oral pathology, this is a new study, a new thing that has come up in the market now. We call it as organoids. Earlier we used to do animal research. Now what they are telling is to cut short the animal research because of all this animal people against torturing animals. Now the FDA, which is the regulatory authority of USA, has even approved we can use organoids for testing the new drugs, etc. Organoids are small organs which are grown in the lab using the stem cells of individuals. There is a study going on in US. They are taking on autism. They are taking the primary teeth which are falling down, which are being shed in the case of kids. They are taking stem cells from those exfoliated teeth. They are then stimulating the stem cells to divide, and they're making organoids, brain organoids. And recently I was just checking on them, and they were saying that there is a difference in the brain size between autistic children and normal thing. And autistic children tend to have a larger brain size. It could be because of a high, this could explain the high neural activity in such autistic children. This is a huge market because all the drug companies in the world, they have to test their drugs in organs. And getting animal approval for certain types of tests is very difficult, and some are not allowed also. In such situations, this type of organoids can play a huge role, and the market rate is about $3,000 million, and for projected market rate, but I'm not going into that. But what I want you to tell is the impact that can be done by conducting research in oral pathology is as huge as this. So this has to be tapped. The potential the youngsters have to be trained in clinical research in such a way that they are able to do their own projects or do their own startups. The second thing which I would like to tell you is, again, drug delivery. Drug delivery, anyone who has an option to develop a drug which can be, we can say, painless, where it can be given reliably and in a controlled manner, he is sitting on a big idea. And one of the main things that are happening is when patients who are demented, patients who have dysphagia, types of drug delivery like buccal drug delivery, it has a huge potential. And you can use the same platform once you develop a platform for multiple drugs. So the potential is so huge, but somehow we have not worked on drug delivery system for some reason in dentistry. Or the main thing, the minimum thing I see is somewhere in periodontics, somewhere for gingival wafers or etc. etc. But there is nothing big happening in dentistry where we can use it for systemic drug delivery. So this is also a huge potential which should be used, and oral pathologists can play a huge role in that. And third thing is the CAR therapy, which is also just to make it to make you understand that it can be done by the oral pathologist. Here they are taking the samples of patient, they are doing genetic engineering of the T cells, then they are injecting it back into the blood of the patient so that it goes and clears up. It can go and target the antigens in the tumor. But problem with solid tumors like oral cancer is, as you know, the matrix is it's like a barrier. You have aberrant blood vessels, so blood supply is also an issue, and the cancer microenvironment is also it prevents cells from entering. And as I was talking about the implants, the beautiful part of oral pathology is all our tissues are accessible. So we can use CAR therapy for oral cancer. It can also be whether it can be used for pre-malignant lesions to stop it from progressing to malignant lesions. These are all high potential ideas which can be used by oral pathologists to develop new startups and make a huge difference in the society. Okay, so to put it in context, usually stages of research is done either in the lab either in the preclinical lab or in the clinical trial. In all these three areas, we will be able to work as oral pathologists. And therefore, it is essential that the academy, or I mean the academics as such, from that point of time, we are giving an option to our oral pathologists to also equip themselves with new skills which can help them with research. So for this, with respect to in vitro, practically what I found was I was able to handle the imaging part, but when it came to analytical part, coming to tissue analysis and all, I had at that time I was finding it difficult to decide which type of instrument to use, where it is available, and how to approach it for doing this type of studies. So if these all could be trained when you are in when somebody is in their PGs, they can be a big workforce for the industrial research, and opportunities could be big. Similarly, for preclinical research, I had no idea on how to handle, because I was touching a mouse for the first time in my life in the lab, and I had no idea about the anatomy of the mouse, and we had to somehow work out the, what you call it, as the anatomy of the mouse with respect to the maxilla. And we didn't have enough literature on that, because this was a completely new concept which I was working on. I was working on a new concept of delivering drugs from the maxillofacial region to the brain. It happened by chance. So I didn't have any reference books. I didn't know which animal to use, and how to move forward, whether I should go approach the private agencies or to approach the government agencies. All this, if we could have some exposure when we are in the academics, it will help us in starting the company. But luckily, I was able to meet one person who was Dr. Pandian, who was a postdoc from Harvard University, and we were able to form a good team. And because of that, I would have worked on, I don't know how many number of mouse heads I was able to work, because he was allowing me to work on all the animals that were being used for other research. So I was able to work out a surgical procedure. So we had to work really for a few months just to learn the anatomy and to plan the surgical procedure to do our preclinical studies. All these things, if we can do earlier during our PG days, we can save lots of time. Lots of time, when I mean, is of years. So it is a big thing if we can learn it in the PG stage. And coming to clinical trials, yes, clinical trials, we are experienced handling patients, and many of us are also clinicians. From that point of view, it has been all beneficial for me as an oral pathologist to be an oral pathologist and also handle the clinical trial and be a part of my team. So that way, I feel being an oral pathologist was the biggest asset for me during the entire process of my research journey. And just to give you an introduction of what we did, the first thing I came across was this thing called primary cilium. That time I was working with a team of nephrologists. So in the nephrology clinic, we used to come across this thing called cysts, and we were used to sit and discuss, and then they used to tell me it is used to be because of a genetic problem, which is because of polycystin 1 and 2, and this is commonly seen in primary cilium. In that way, we happened to see a case which also came with a dentigerous cyst, and based on that, we proposed a new hypothesis. After I proposed this new hypothesis, I wanted to patent it, so I went to the lab, I went to the patent office, and there they told me that in India, as far as India is concerned, you cannot, even if you identify a new thing or you are proposing a new hypothesis, you cannot patent that part of it in animals or humans, except microorganisms. This is important for us. Second thing is, we cannot patent a medical procedure or a surgical procedure. Patent a product, but you cannot patent a technique as such. Manufacturing technique can be done, but when we treat humans or treat animals, anything surgically done or medically done cannot be patented. Same holds for any new structure we identify under a microscope, or we identify a new part in any part of the body, that cannot be patented. This is very important for us, because it is also important, if you are identifying something, to bring it out and put it that you have done it. When we were doing this, we didn't have the preprints, which was the bioarchive or the medarchives. Now, from 2013, I think we have the bioarchives, which is for non-clinical subjects. And for us, we have the medarchive, where we can start and put the clinical trials, etc. Always keep in mind, if you find something new, just check out whether you can patent it or you can publish it. And if you can patent it, always first patent it. If it cannot be, if it is something which you can't patent it, then make sure that at least you put it in the preprint, get the date that you are the first to do it, and then you can work on it and put it in a high impact journal later. This is important because even Marie Curie lost something because she published some finding late, and by the time somebody else had published it. So this is a very important thing. As researchers, we should keep in mind the date, the time is very important. Who does it first is very important. So since I couldn't get an implant, I couldn't get a patent, I was working on other concepts. So I was working on dental implants, and one of the commonest thing which I found was that abutment screw was getting loosened often. So I thought, why not have an abutment without a screw? And for that reason, I cannot give you the full structure because of the implant, because of the patent. So we developed a new device in which we have the abutment and which didn't have the screw which I had shown as earlier. So then, as we were working on this, I also came out with the idea, because since we don't have a screw, we will be able to access the implant through and through. Why not use it for drug delivery? So based on that concept, I started working on brain drug delivery. This was a completely new concept, as I already told you. I didn't have much references to work. So this was more based on the clinical experience, as well as I was reading the literature. And from there, I thought that if we can deliver the drugs into the maxillary region through the perineural pathways, which adenoid cystic carcinoma, etc., take, the same route can be used for delivering drugs into the brain, because brain is very special, because the blood vessels, they have lined by the tight endothelial cells, which is called blood-brain barrier. It does not allow any substances to go from the brain, from the blood into the brain. It is a very protective mechanism. So even if we give drugs, it doesn't enter the brain. So by using this technique, I wanted to bypass the blood-brain barrier and enter the brain. I worked with the team which helped me, gave me access to the mice models. And we injected, as you can see, we injected into the maxillary region, and we were able to detect this is antibody. We were able to detect it in the entorhinal cortex as well as in the brainstem. Brainstem is where most of the brain cancers come. Entorhinal cortex is where the memory is affected in Alzheimer's disease. So these are all important areas. And as an oral pathologist, I was able to appreciate all this along with my team. So I feel it was a blessing, and I would like to thank my professor and all my faculty for teaching us the basics of oral pathology. Without this would not have been possible for us. And while we were working on this, we also came across, we did something called as in vivo scan. In vivo scan is something where you can scan live animals. You can inject a drug which is fluorescent, and you can see whether it is going to the areas which we want. So I was not even aware such an instrument was existing. So once I was coming, I contacted a professor in Singapore, and I was requesting them, please allow me to come and do it. Finally, they changed the name of the lab because they were so fed up with my request. So once I was coming from Chennai, I happened to get down at an institution for some work, and that person was kind enough to take me for a tour of the lab. So while we were going through the lab, he showed me an instrument, and this was the instrument which I was trying so much to go and do it in Singapore. So what I want the PGs, if in case any PGs are there, what I want you to know is it's important to know the types of instruments that are used for research, where it is available, and how it can be used, and the procedure to be followed. If you are aware of all this, in research, even a small delay can delay everything by months or by years. So you tend to save this by being aware of things that is happening around. And while we were doing this study, somehow we identified that the opposite eye was also getting the stain, and we identified that if we could inject the drug in the sinus region and the maxillary region, we were also able to target the optic nerve, which is normally not, which is very difficult to target in the ophthalmology clinics. And there is a lot of conditions where the optic nerve and the optic pathways are affected, and they are not able to treat. This could be even genetic conditions. And by chance, this was by chance that happened, because we saw the eye also getting lighted up. So we went back, we checked the eye, and this is the retina, this is the optic nerve, and all this can be identified as an oral pathologist, which specialties in dentistry cannot do. This is our specialty, and this is something which is our asset, and which can take us to places as far as research is concerned. And this has to be used. We cannot restrict it to dentistry and academics. And while I was talking with ophthalmologists, they were saying, yes, if we inject the drug in one eye, it is also seen in the other eye. And the reason they were giving was they were also not aware of why it is happening. And one of the assumptions or one of the hypothesis they were giving is it could go to the blood, and from the blood it can come to the eye. So since we were working on already this concept of eye brain, we have proposed a new hypothesis saying that because of the optic chiasma, the optic nerve fibers are crossing over, and because of this we will be able to get the drug in the opposite eye. So this is a concept in ophthalmology which has gone from dentistry, and I'm very happy we could do it from oral pathology for that reason. And then while we were working on this, we had this COVID coming up, and we had symptoms which were important for us, like ageusia was there, and happy hypoxemia and cytokine stones. All these things were very famous at that point of time. And since we were already working on this maxillofacial nose pathology, and we targeted a region called as nucleus tractus solitarius, which is in the medulla, and where all the 7, 9, and 10 cranial nerves go and relate. And because of this, we also said it is not only the lungs, it is also the brain that is going to be affected. Right now, we have neuro-COVID is one of the sequel of COVID, which a lot of research is going on. Similarly, brain fog is going on. All this concepts, I wouldn't say it is based on my hypothesis, but of course we published it long before all these concepts were, research on all these concepts came up. Similarly, we were able to connect pulmonary edema with an inflamed nucleus tractus solitarius. Cytokine storm also we were able to connect it with nucleus and the vagus nerve. And we also proposed, even before WHO had proposed, we had said that maybe if we can use steroids before a person deteriorates, we will be able to reduce the mortality of patients. At that time, I had a good friend who is a cardiologist in Pondicherry, Dr. Manimaran. He's also my mentor. And I was just discussing with him about this, and he said he was also finding that some patients who were normal suddenly were deteriorating, and once they go to the hospital and the deteriorating stage, it is almost the mortality was very high. So while we were discussing, we were thinking, why not use some marker in the blood to identify which patients will be going into the crisis and stop it before that. So we worked on something, and we got the C-reactive protein. We use that C-reactive protein as a marker and put patients before they were patients. If the CRP was going to go up, we started introducing oral steroids at an early stage, and if it was more than tenfold, we were giving them IV. And the paper published in MedArchive, it is for 25 patients, but I don't know how many patients we had worked on because the phone was always ringing. We started with our friends through word of mouth, other patients, the patients we have not seen, but everything was online, and none of the patients, whoever we were handling as a team, we did not lose even a single patient, especially when there was a demand for oxygen. So that was one good part, and I'm happy that also we could do from oral pathology in collaboration with the medical team. And this is the concept. Generally, if they had mild cases, they were putting patients at home. Then they were asking them to come to hospital when their symptoms were bad. But most of the times, this always ended up in a problem. So what we did is, we didn't wait for them to worsen till hypoxia comes. Before that, we used to use the CRP as a measure, and then started introducing steroids, and we could save lots of lives.
It is a rare.
Pardon? Can I continue?
I think so. You can continue. It's just like somebody has just turned on the mic. I think you can just continue.
Okay.
No problem.
Okay. And during this time, we also proposed having a nasal route of drug delivery because of since we were working on the same route. Now we have a nasal vaccine, as well as nitric oxide was also given nasally. So this was what I am saying was already published in 2020 in ACS Neuroscience, available online. And so this type of research, multidisciplinary research, we were able to do because we were able to work with multidisciplinary teams. So the concept of isolating ourselves as oral pathologists keeping the research within the lab is not going to help. That concept has to change. The labs have to be open. New people from other departments, other disciplines have to interact with us. We also have to interact with them, get new ideas, and those ideas have to be taken from the lab to the clinic for the startups to come. And after that, I was discussing with a neurology friend of mine. He's a head of neurology, and Dr. C.T. Suresh, and we were talking about how we can take it for brain drug delivery. Either should I take it for brain cancer or whether I should take it for Alzheimer's or Parkinson's. Then we found that Parkinson's disease had a unique thing, because patients after 5 years of use, initially they can take oral tablets, but after 5 years they stop responding to oral tablets, and some of the patients have difficulty in swallowing the drug. Some of them lose their memory and they have difficulty, they don't remember, even if you put the drug in the mouth, they forget to swallow it. In such conditions, we were wondering whether we can use our system to deliver this drug. And when we compared it with the existing conditions, for example, this is called as deep brain stimulation, where they put an electrode, they drill a hole in the skull and they put it into the brain. So this is a very invasive procedure. It is very costly for the patients, and you need high-tech instruments and highly specialized doctors to do that. Similarly, they do that, or they make a hole in the stomach and directly pump the levodopa into the stomach, because it is absorbed in the duodenum. So this has so much complications, because the tubing can get blocked. The patients can have difficulty with peristalsis. And the third thing is they are using ultra-focus sound, where they use focus sound to open the blood vessels so that the drugs can get across into the area. But when you open it, not only the blood goes in, other things in the blood also, not only the drug goes in, other things in the blood also can go in and cause infection to the brain. And we have a levodopa pump, which is being used under the skin. This is it can cause painful procedures, and it also has other complications related to apomorphine. So we were looking at a potential. We saw there is some use for this, and I was thinking whether I should put an implant in the maxillofacial region or I will extend it much further. So I thought I have to make it much more easier. So I used root canal treated tooth, and we used a modified crown as our device. And using that, we were able to. This is the case, and here you can see this is the premolar region. He is a 96-year-old patient. And we did the root canal for the patient. We put the crown, and we were able to deliver the drug through the root. And ready? I need the video. Just a second, please. I am putting the video. So you can just check out. This is the patient which we treated through the root canal. And Parkinson's is a condition because where you don't have dopamine, and because of when there is lack of dopamine, patient develop tremors or they are having difficulty in walking. And this was an 86-year-old patient, and we administered a drug called levodopa, and we used 1/20th of the dose. This is before the treatment. You can see the hand shaking, and he has no coordination with his fingers. The movements are very slow, and he's not able to lift his toe because they usually undergo freezing. They will not be able to get up from the seat. Now we gave a very low dose of that drug, and this is after the procedure, within 5 minutes of the procedure. We'll go to the next slide. Escape. Escape. And so before I conclude, I want you to know that one of the more commonest complications that we have, confusions we have in academics is whether we should patent it or whether we should publish. So once you get a beautiful idea and you have the capacity to find a solution for it, you have the people skill to develop a nice team, which you can use it to develop your idea and bring it to the clinical side. For all this to happen, you need two things. You need a good team, and you also need funding. And funding usually you will be able to get from institutions as well as from government institutions as well as from private agencies if you have a good patent. So, but we cannot patent everything in India. As I said, if you have a product, I can patent the device, I could patent the implant, but I could not patent the primary cilia. So I can patent the drug delivery system, but the technique I will not be able to patent. So these are things which you have to weigh and see whether it is something which is useful, which can be taken forward. If you should patent it, always first patent it. Once you publish it, whether in as a preprint or as a publication or as a news report, once it is in the public domain, you will not be able to get a patent. So this is the important thing which I would like all my colleagues to know about this. And to conclude, oral pathology, of course, is a highly intellectual subject, but it also gives us very highly qualified professionals to do excellent research. And for that, we have to have a different concept. The way of looking at things also have to change. We have to look at things which can be translated from the lab to the clinical side. At the same time, our students or whatever juniors are also coming up. They should also equip themselves with new skills and techniques so that they can make themselves marketable in this highly demanding field of industrial research. So this is what oral pathology is, and something we can always be proud of. So thank you so much for this opportunity. I hope it was a useful discussion. So, thank you.
I call upon Deepu sir for your valuable inputs.
So the sir, like, it is really a great presentation, and I feel like it's a great eye opener. Like, I've been thinking about like how we can, like, because like being a pathologist, like being in an academic institution, it's not going to work at all, like in future, because everything is saturated, and we have to start looking for the new avenues. And I'm very happy that like there is somebody out there like doing all this wonderful work, and who's utilizing the skills that they have developed during their post-graduation and just been utilized to do something new. And I really appreciate, sir, like for this wonderful work that you're doing. And one important thing that I felt like is like what you suggested, like, because everybody will ask like, what am I going to do by learning all these things that I'm learning in the oral pathology? I'm not going to use it in the practice. But that is where like you are told about like where the medicine, dentistry, basic sciences and clinical sciences are all coming at one crossroad that is called the oral pathology. And an oral pathologist will be able to deal with the in vitro research, the preclinical research, and the clinical research. Like we are like a clinician at the same time a basic researcher. So we have the skills of the basic sciences, and at the same time we'll be able to do the clinical trials. So I think that we are all sitting in a gold mine, and we are not really understanding the potential of what we have. And sir, I feel that this is something that is really great. I have few queries regarding and doubts regarding the thing. So one is, sir, like you talked about the patents. So is it okay, like, because like if you take in only an Indian, you may have to go for a US and a European Union patent, and separate, and that is going to be exhaustively expensive. So how are we going to manage as an initial researcher, like with minimal funds? How are we going to manage that?
See, basically, if you are going to patent something, it is mandatory you first patent in India. It is a legal obligation.
Okay.
If you go directly to a foreign country, you can be arrested.
Okay.
So first thing is you should always file in India. Then you have to give a letter requesting permission to file in a foreign country. And if there is any objection, they give you a letter, or you are free to file the patent after 6 weeks.
Okay.
For this, you need a because I didn't have a lawyer, because when I was searching for a patent at that time, this all this patent attorneys, all this exposure was not there. So what I did, I learned how to file a patent from the net online. I filed my own patent in India. I learned the procedure online. Then there are two ways of doing it. One is called a PCT route, patent cooperation route. I'll just give you the gist. Another is called as a Paris Convention route. Okay. If you are going to take Paris Convention route, you have to file within 1 year in a foreign country. Okay. Otherwise, you can file something called patent cooperation route, which you can file in India. You get a period of 2 years to see whether your thing works or not, and you can then decide whether you want to file in foreign country or not. Okay. You can do your study by that time and see whether it works. If it works, you invest in the foreign country. Otherwise, you don't invest in the foreign country. Okay. Second thing is, in US, you don't need a lawyer. In India, you don't need a lawyer. If you are competent enough to draft your patent. Of course, it needs quite a legal approach because each word you use is going to make a big difference. But basically, if you are smart enough, if you can read and do your homework, you can still file a good patent in India on your own. Use that patent, go and file it in US. Everything can be done online from your home.
Okay. Okay.
So even if you are filing an US patent, there is a formality, some forms which has to be notarized. You have to send. Initially, there are some procedures, but once it is done, US is a very very easy way of doing things. Though examination is very tough, it is very easy of doing it. So in India and in US, without a lawyer, you will be able to do. If you are going to do in Australia, you just need an address to be given, a local address to be given in Australia. Same so in Canada, I think now they have introduced a lawyer to be needed, but in Europe, it is you need a lawyer and it is a very costly affair. So if you are going to go into Europe, you have to really think how much money you are going to invest. But India and US, you can do it on your own and you have to pay only for the patent costs. So that is not going to be a huge.
So you also mentioned that like initially when we are starting and if you are approaching to a company, you need to have a proof of concept with you. So up to that place, if you want to reach, you need to have some initial funds. And so is there any way where we can be able to gather that initial funds to reach up to the proof of concept level?
So that depends on, as far as India is concerned, if you are in an academic environment, getting funding from the government agencies is easy.
Okay.
Rather than like me, if you are going to do, it has to be, I had to bootstrap my study. And it had to be, we had to do it was more tough for me than like what an academician will be able to do.
Okay.
So the plus point of an academician is you can do research much easier than a person outside.
Okay.
So you can always approach the agencies, but even all that you need is I'm not saying do it in 100 patients or do it in 100 animals. Even if you are able to do in 1 or 2 animals and show them that this is working, to make it into a statistically significant study, it works.
So one more thing, what I want to know that from the proof of concept, when you are approaching in a company, how does the negotiation goes? Like, how is that profit sharing? Like, how are we going to make sure like we get our the rightful due to ourselves? Like, now how do we do that?
That definitely needs a lot of homework to be done. It depends on on individual projects. I won't say a single formula will work for everything. It also depends on the type of company you are approaching. If the company has funds to pay you, they have. If it is a bigger company, the negotiation is different. If it is a smaller company, negotiation is different. So it is based on the project and the company. And negotiations, you definitely need a lawyer. You definitely need an auditing agent, and it has to be done professionally, and it has to be done professionally.
So definitely, sir, I think it was a great eye-opener for us, and I think we will definitely keep in touch, and I think there are a lot of things that we can do in future. So congratulations to you, sir.
Thank you, sir.
Any queries people can? I think somebody has raised the hand. Can you if you can just type the queries in the chat box, I'll be able to share it with Dr. Anu. Otherwise, you can unmute and you can ask the queries.
Dr. Anu, can you just elaborate on your findings on primary cilia in integer assist? The work, your initial work.
Okay. Usually, we know that the PATH gene is there. It's one of the problems with primary cilia. So we also found that calcium signaling can also be affected, and this can lead to, whenever this PATH gene is affected and there is a problem with the calcium signaling, it can lead to proliferation of cells. It removes the brake and allows for proliferation of cells. When this proliferation of cells take place, it forms what you call it as a mass, through which there can be a transudate happening into the tissue. And what we proposed was, since the lining must have been present on the surface of the enamel also, but because of the pressure, that lining gets detached, and we are able to get a cyst with the tooth inside. And this is also, even in the kidney cyst, whenever there is a mutation of the PC1 gene, PC2 gene, along with patch and calcium signaling pathways, there is an abnormal production of matrix, which helps in, which I felt that that must be the reason why it is getting attached to the CE junction. Along with transudate, there is pressure. It tends to put the cells, exert the pressure on the cells lining the enamels, thereby they are lost, and we get a cavity with this. This is the thing we propose. There has been some 7 or 8 studies after that. One is from Calicut also, I think. And right now, I just before coming, I was seeing some European countries also have cited our article, and they have also proposed a new hypothesis based on this. But they have proposed necrosis of the cells at the center. We propose transudate happening.
I believe we were able to demonstrate the primary cilia in dentigerous cysts, right?
Yeah, we are able to see it in dentigerous cysts, and they also identified that, just like I was talking about autism, where the brain size, even the size or structure can be different. In the case of keratocyst, they were able to identify a different type of structure for primary cilia. It was absent in the case of radicular cyst. So these are things which can be significant clear findings, but again we have to go into the genetic level to identify the problems basically.
Okay, thank you.
So there has been few comments that has come. One is like Dr. Vijay Lakshmi has said, thank you for the insightful presentation on the innovation research in oral-pathology. Dr. Anoop, your expertise and passion are truly inspiring. It's really great. So one more thing I want to ask you is like many a times we have a vertical thinking kind of approach. And what we really need is a lateral thinking approach, and we need to make our postgraduates think for innovative ideas. Can you suggest some ways of exercises or some ways to inculcate that kind of a culture into our academic practice?
I think we are more focused on a result-oriented type of research. But when you are coming into this type of research, we say if you have to fail fast. It is completely opposite of academics.
Okay.
So we don't want to waste time. We don't want to waste money on it. If something is not going to work, let us find out that it is not going to work out and finish it with it fast.
Mm-hmm.
So it is little different from academics. So we have to start to learn to accept that sometimes results don't come as expected. Mm-hmm. So the projects can fail. Mm-hmm. And we should start assessing students based on a type of divergent thinking they are and the risk they are going to take, rather than the end result or the they are getting it, because research can always have both a positive result or a negative result, and we have to handle both the same way. So I think that way, if we can encourage them without a result-oriented way of assessing people, mm-hmm. I think they will be able to do it more with more confidence, and they would be looking to take more risks.
I think that's a very important thing in our academic. Dr. Sudhi has raised the hand. Madam, can you just, yeah, please.
Yes, sir. I had a very basic question to ask, because we'll be writing articles and brainstorming is suddenly when we're reading something or writing something, suddenly some idea will crop up in our head. So in such a case, how do you know that something, that idea, which it is worthy of a patent or not, or whom should we approach or whom should we consult? Like we don't know whether this idea is good or this idea is bad or something like that.
All ideas are good. So what we try to do is, if it is something, a new idea, if you have got, you can always go to the patent search sites. Okay, you have something called as Google Patents. You go and type what is your keyword into that. You will get all the patents which has that similar idea. So basically, when you are going to develop an idea, there are two things which you have to know. One is something called as novelty. Novelty means your idea should be new. It should not be, or a product which you are making should be completely new compared with anything else that is existing. This is easy to pass. The second thing is something called as obviousness. Obviousness, and when you go to US, if you have a mouse, they will bring a box, they will say a wire, and they'll say this wire and the box you connect together, it becomes a mouse. I mean a computer mouse. So that is the difficult part which you have to cross over. When I was presenting my, I told you I didn't have what you call it, a lawyer. So when I was presenting it in US, finally the way they allowed me to get my patent was, my entire system was there. I had a tube and a cap which was not seen in any other thing in the world. Because of that, not because of the drug delivery system, because I had that which was not available which was not seen in other parts of the things which they were trying to bring, I got the patent. So, thing is, first, as you said, it is important to know whether it is novel. You can go to Google Patents. You can even do a Google search. There is US patent site where USPTO search. You can go there. European Patent Office is their EPO search. You can go and put that idea and see if somebody else has done it. If they have done it, there is no time wasting on it. But if they have not done it, and if you have something new, you should definitely try.
Yes, sir. Thanks a lot. Thank you so much.
So one more person had raised the hand, Dr. Venkatapati, I think. Sir,
Ramesh, sir,
yeah, please.
Oh my God. Good evening, sir.
Yes, sir. Oh, sorry, sir. Ramesh, sir.
So can you please show the video, sir?
Good evening, sir.
Anoop,
Good evening.
it is wonderful. It has been a wonderful inspiration talk.
Thank you, sir.
And only thing is, I'm not going to raise anything about the research work because you have gone long way. I know how difficult, how much of struggle you would have come out. But this definitely has shown the way for the budding oral pathologists and who has to come out of their thing that they have to come out of their lab. They have to come out of the institution. And you have shown the way. You have shed a lot of ideas, and the oral pathologist should no more sit back into the thing. And now you have come out of HND, you have come out of antigen, antibody, everything you have come out. You have, as a oral pathologist, you have showed the way how you can push yourself into the field of neurology, ophthalmology, cardiology, pulmonology, and whatnot. But you have climbed the ladder of oral pathology, which you have not forgotten. And this is the lesson which the budding oral pathologist should understand. No point in just saying that they don't have any future and so on. But they have to realize bright future is there in any field, provided they have a lateral thinking and come out, and they have to struggle. Without any struggle, there is no success in that. I am very, very proud to see that you have come long way, and it has been a wonderful thing to see that you have crossed the many crossroads, and I'm sure that you have paved the way for many of the oral pathologists in India, and I think many of them they should follow, and they should understand what potential we have. As Deepu has already pointed out, we are sitting in the gold mine. The only thing is we are not using the gold, right? All the best, wonderful, and I'm happy that you have been a very high inspirator for many of the young budding oral pathologists. And I also thank the people who have chosen the topic and given the right talk to the young people, because they all think that it is a oral pathologist means they shut themselves within the lab. They have to come out of it. Unless they come out of it, they cannot succeed. So it is right time. Anoop has shut out a lot of ideas, a lot of things he has given out. Catch hold of that and come out and have a bright future. Thank you so much for the organizers as well as for Anoop. And Deepu has already shown how, as oral pathologist, has done. He has been establishing in Kerala, and like that, Anoop has gone from Bay of Bengal to now the Arabian Sea shore, and now he has to cross the continental thing. And I'm sure that as a teacher, I'm extremely proud and happy that I have such a wonderful student. Thank you so much. All the best.
Thank you so much, sir. I would like to share that the first interdisciplinary meeting I had, sir had taken me to JIPMA. That was my first exposure to, medical conference. And now now we are taking this, after that first meeting in JIPMA, now we are taking this Parkinson's project. We have done a 24-hour monitoring of the patient. We are presenting a maxillofacial dental technique in a neurology conference at Philadelphia on September 29th. So that will be the first time we are presenting this in an international conference. Thank you so much, sir. That JIPMAR was the turning point for me, and I owe everything to you. Thank you so much.
All the best. All the best. Thank you.
Dr. Anoop, I should say that you're so blessed and fortunate to have a teacher like Ramesh, sir, who has shown the way for you the initial place. So I think you're really blessed to have a teacher like him.
I feel this is
No, Anoop has climbed on his own. Anoop has climbed the ladder on his own. It is his potential. It is only the initial thing, nothing. Anoop is his own efforts. Yeah.
So the first one,
Madhija, I'm happy that you have opened out the thing for many people.
Thank you, sir. Thank you, sir.
Good job. Thank you.
Thanks.
Thank you, sir. Anoop sir, can you please stop sharing your slide?
sure.
So I request all of you to switch on your cameras for a photograph together. Kindly switch on the cameras. Mahija ma'am, will you please take it?
One second.
Yeah, can all of you just switch on the cameras, please, so that like everybody's face will be there, like be really nice. Yeah, please.
You can,
Ramesh sir, can you please switch on the camera, sir?
Yes.
Thank you, sir.
thank you.
Okay. Thank you. Now, on behalf of KSOMP, I request Anoop sir to accept the certificate of appreciation.
Thank you, ma'am. Thank you.
And I request Deepu sir to accept the certificate of appreciation.
Thank you. Thank you.
So, thank you once again, Anoop sir, for that enlightening session. And that comes